welcome everyone. Good evening. Welcome to Coproduced Care. And today we're carrying on our stream of live streams that is focusing on commissioning. So we had a fantastic conversation with an organization called Compassionate Commissioning, and that was yesterday. And what we were doing there is that we were trying to open up the idea of how to do commissioning slightly differently and involving the community. It was a lot about organizations that don't normally feature in commissioning for social care, and seeing how we could do it slightly differently. Today, we're going to be looking at how we commission in terms of providers, their experience of commissioning, but also the experience of commissioners and how the challenges that they face can impact the way that they commission and who they commission. And this has been done differently from how I usually do it, because I usually get to meet our guests quite extensively. And although I am very familiar with one of our guests, Melanie Weatherly, I haven't spoken much to David Hambleton, who we're also going to be interviewing. So this is going to be really exciting for me. I'll be asking some questions about his views on commissioning. But as always, we will, if you are watching live, I know that a lot of people do watch us on playback, but if you are watching live and you want to ask some questions about commissioning, then please do use this platform to do that. Let's start a conversation about what's working well, what's not working well, what we could do differently in the future, and of course how COVID might change that. But before we get going, I really want to encourage you, as I always do, to follow us, to subscribe to our YouTube channel. If you're watching us on YouTube, if you're watching us on Facebook, then you can like our page, and also just forward what we're doing to people who you think might find this interesting and useful. So please do feel free to do that. And what we're hoping to do also is in the next few days share with you the results of our survey, which we did recently on COVID-19 vaccine. So what we did is we found out on the grapevine that there were some people who worked in social care who were quite reticent and worried about the vaccine and weren't sort of waiting to line up to take it. And we wanted to really unpick why those reasons were and find out how we could maybe encourage people or get the right information to them to explore what the vaccine might do for them, and how it might help them, and to really get some more information out. So, well, the results of that survey, we're currently just writing that all up. We've got over 300 people who replied to it. They all work in social care in some capacity, some as managers, some as people who work on the ground, some social workers, carers. So we've tried to really look at social care across the different variety of jobs that people do. And it is very interesting. It's promising, the results that we've looked at so far, because most people do want to take the vaccine, which is great. But about 40% are saying that they won't take it. So we have asked them. The interesting thing for us is not so much the statistics, but it's the reasons behind why people are reticent about it or worried about it. And I think it's not necessarily down to people are totally anti-vax or they just don't want to take it at all. Some people just have legitimate concerns. There's not enough information out there. So we're going to share all of that with you. Quite transparent about the work that we've done. So if you want to find out more, then do go onto our website, coproducecare.com, sign up to our mailing list, and we will share with you the data that we've collected, because I think it's very important at a time when not many people who work in social care are directly asked about the issues that they face, especially during COVID-19. It's often filtered through other sources. It's really nice to have actually directly asked them and for their views to be represented. So that's what we try to do as an organization anyway. That's why we've got this YouTube channel set up, these live streams to speak to people who work in social care. So hopefully that will be interesting. And of course, do keep in touch with us if you want some more information on that. So what have we got here? So this is our second live stream, and we've got one more next Monday, 7th of December, 5 p.m. on alternative visions of commissioning. And that will be to look at the Buurtzorg UK idea, and a lot of people will have heard of that. So hopefully if you want to know more and you haven't heard of it, then tune in, and if you have heard of it anyway, still tune in, because it is a different model, and it's very interesting, and I know of it, but I don't know huge amounts about it, and I've tried to get this guest on for several months, and finally got diaries to coordinate, so that's another one to watch out for. But of course, we're going to introduce our guests today, and I'm going to start off with David Hambleton. Hello, David. How are you today?
Hello, Sophie. I'm very well, thank you. I'm very pleased to be with you. So thanks for having me.
Thank you for coming. And you're the former CEO of South Tyneside CCG, now the officer, is that right, on my notes?
I was, up until April this year, the chief executive of the CCG in South Tyneside, up here in the northeast of England, and I left that role in April. And now I no longer work for the NHS, so I'll feel free to give you a view about commissioning, which is hopefully warts and all. So I'm hopefully tell you what the good, the bad, and the fairly ugly around commissioning is.
That's nice. That's nice to have a balanced view. And the way that we got into contact with you is through someone called Toby Lowe, and I've been told that you're a prominent leader in systems change for person-centered commissioning, which is great news, and developing new relationships across community and services. And we actually did a live stream with Toby and his human learning systems approach to commissioning. So thank you. There we go. That's come up now. And I think this, can you bring that up again, Arnie? Okay. So this is actually a screenshot from one, for anyone who doesn't know, from a document which you can Google and read about these human learning systems. And I really enjoyed actually listening to him, and anybody who's watching can go back and find the interview that we did with Toby Lowe. But we're not going to talk about that. That's almost theoretical, I think. It's a great idea, but of course you've got lots of experience about being person-centered. So for you, what does being person-centered in commissioning mean?
And I think I'll probably start with what it doesn't mean, because people have a view of commissioning and commissioners as somehow being very remote from people in their communities, people who are probably in charge of money and who write contracts and specifications for services, which seem really often to be unrelated to what our individuals in their homes and their communities really need. So I think the traditional view that people have, if they have any idea at all about what commissioning is something like that, something which is very unpersonal and really unconnected to them. We didn't feel that was right, and there are a growing number of people, we think, in the country, including people like Toby, who feel they need to get better connected with their communities and also with their partners around them. So from our perspective in South Tyneside, we deliberately set out to have conversations with partners, particularly our council, our mental health organisations, third sector organisations, and wherever we could, with members of the public. So we were starting from the point of not deciding what we thought people wanted and needed, but actually trying to listen to other people and take a much broader view of how we decide what people need. So that was our first starting point, and that felt to me to be very different to a traditional view of commissioning, if that makes sense, Sophie.
Yeah, it does, but I'm intrigued to learn about what that means. If you've got any examples of how your approach you feel is different from how commissioning is done at the moment, and maybe kind of talk us through people who aren't really working in commissioning, who don't really understand it, how it's traditionally done, and how care is commissioned, and how you were trying to steer away from that and go more down a person-centered route.
Sure. So let me give you a couple of examples. Firstly, if people think about commissioning from my kind of NHS background, they think about how we have very big contracts with hospitals and community providers, those who employ people like district nurses and community matrons, and we spend a lot of money on services like that, for sure. But we very rarely ask questions about whether those nursing teams, those community teams, are actually delivering what people really want. So we decided that we wanted to take a different view. And the example I guess I'd give you would be something called continuing healthcare. You and your listeners are probably very familiar with continuing healthcare and the criteria that sit around it. But basically, it's a way of the NHS trying to ration whether they pay for someone's care or not. It's an extremely bureaucratic and complex process that we've developed over years to decide whether the NHS or social care should pick up the bill for people's care. And we said, hang on, why are we arguing about who pays? Why don't we start with trusting some of our frontline staff and the people who they're in their homes sitting opposite to decide what it is that they want in terms of their personal care and support. So we deliberately, as a CCG, said we are going to not have an argument and a conversation about who pays for care and support, but actually just trust our often social work staff or district nursing or community matron staff to go and talk to people and decide between them what it is that they want in terms of their care, and then go and get it, and then not argue about who was paying, and the CCG would simply pick up the tab. And we started doing that in a small area, and then everybody liked it so much, we decided that this was the way forward for continuing healthcare generally.
That's incredible. So instead of it being a top-down approach of, well, this is what we think is right for you, it was more of a dialogue between the person who, which, I mean, when you say it, it doesn't sound remarkable, but when you understand how things are done normally, and then you hear what you're doing, it does sound like it's something different. And I wonder, why is it that there had to be this tussle between who pays for it in the first place? Is it because that austerity or budgets are so tight that people don't feel that they should be allowing that choice, or is it because of a kind of psychology that people have got into, in that we have to just prescribe the solution rather than have a dialogue with people?
That's a brilliant question, and I guess firstly I would say that it is based partly on the fact that we have a finite resource, so no one has an endless pot of money, and therefore people think that what you have to do is ration it and be very careful about what you're funding. So it starts with that premise. We've also been very good at allowing organizations to have their own rules and giving them their own budget, and therefore people become very protective over that. Councils have had some of the worst financial cuts in living memory, and so of course they're very careful about what they're spending their money on, and the NHS too. So we get this unfortunate situation where instead of talking about what a person needs and wants, we talk about who is paying for it. So that felt intuitively wrong. So the example that I've used, the NHS had put in place locally a 33-step process before that person, that individual, could get the care that they wanted. Now, no one deliberately designed the system like that, but that's what happened historically because of the financial pressures. And we got rid of the 33 steps and said, let's trust the staff who are with that individual, and that's where we should be making the judgment. So the history of it is very unfortunate. But you're right in suggesting that it does take quite a bit of unpicking, because not having one budget for health and care is a problem.
It's incredible, 33 steps. And it's great that you actually took the time to kind of look into that and find that out, because people are probably going through the system and going through the process without even thinking about this and thinking it's even a problem. So it's good that you've actually spent the time doing that, because I'm sure there's a lot of local authorities out there that just work like that without even thinking, what is that doing to our efficiency and to the quality of care for people? So,
And people were waiting, by the way, for an inordinate amount of time. So, and it wasn't the council; it was both the CCG and the council that invented this system, and people were waiting literally months just for a decision about whether their care would be funded by the NHS. And again, that felt intuitively wrong. And some of these people were at end of life, and so no one designed a system like that deliberately, but it took some work to unpick it.
oh, incredible. And what about alliancing? What are you trying to achieve for commissioning in your work through that?
Yeah, I guess we invented the term alliancing, I think, in South Tyneside, and it's largely trying to act like you're all in it together, if I can put it as simple as that. So we managed to have a health and social care system which has separated all of the individual partners and really not allowed them, or certainly not encouraged them, to get together and have conversations collectively about the people that they are meant to be there to care and support. And we think that the description of behaving like you're all in it together is what alliancing is. And often it just involves getting people in the room to talk about, have a conversation about what it is we're trying to achieve. We found that staff have been so responsive to this approach. They really welcome it. In fact, they often can't believe that they're being actively encouraged to go and have conversations, social work with NHS staff, NHS providers, commissioners, hospital, community. All we're saying is we should collectively own these problems. And if we put our minds together, then we'll probably come up with a better solution and not let these organisational barriers get in the way.
So, see how this works and how it's different. Is it just that people are picking up the phone and having those conversations with people rather than filling out a form on the system? Or is there something else, or is that just made all the difference?
It's a really good point, because the difference between picking up the phone to someone and filling out a form is phenomenal. So the fact that we actively encourage people to have conversations with and about their people in their communities has made a tremendous difference. So it sounds very simple, and people often, when we talk to them about alliance, and say, well, what's so magical about that? You know, what's the special ingredient? Well, actually giving people permission to go and have that conversation and trusting them to collectively come up with the right decision turns out is quite groundbreaking. It doesn't sound it to me or to you, but actually, because of the way our system has evolved, it actually is very liberating for our staff. And by staff, I mean our GPs, our nurses, our social care staff, and people in the community really welcome being involved in these conversations in a different way. So alliancing is just living that. Let's really behave like we're in it together, and let's not argue about the money. Let's do the right thing for the person and the system, not for our own organisations.
So that's kind of commissioning at a very personal level. Has anything changed for you commissioning at a more strategic level? So I know, being a care provider as well, that a lot of the times you'll get an email through saying there's a tender going out for a framework, for example. Frameworks have become more popular. Do you find that that's pretty much the same, or have you done something slightly different with commissioning on a larger scale for a part of the CPD?
Yeah, it's a really good question. We almost never put out formal procurement and tender processes, because we always feel that we can have a better outcome if we talk to our existing providers in the system, our existing people, and allow them to collectively come up with a solution. So we hardly ever put out formal tenders. We'd much rather work with people as partners. It's why it is very important that we demonstrate that we trust the people who are in the system, and equally, once they have that feeling that we as commissioners trust them, they start to behave differently as well. So we hardly ever need to put out formal tenders, and we try increasingly to not make financial decisions, even big ones, in the CCG alone. So even where, for example, last year we suddenly found ourselves with £2 million of extra funding to the CCG, which was a nice situation, I'll tell you. I can imagine. And rather than deciding what we spent that money on, we said to our alliances, and those are the kind of smaller groups with specific interest areas, what is it that you would like to spend the money on? So we asked them for their ideas, rather than us sitting in the CCG executive committee and saying we're going to spend £1 million on continuing care or whatever. So you can make even quite large scale strategic commissioning decisions in a different way, although it is challenging for the executive committee and the governing body of CCGs.
And does that mean then that you're more local in your commissioning because it's smaller packages? I mean, how does it work sort of legally? Because I know some commissioning decisions you do need to go out to tender, but are you just keeping it really local and really small, and that's how you're able to have, you've got your alliances, like you say, and you can just go out to people that know the area, that know the community, that can probably know the clients really, because they know the area so well, they can know them better. So do you find that's happening more?
Yeah, there are two things I would say. Firstly, yes to the are we keeping it local? Yes, because those are the people in provider organizations, those are the frontline staff who know people best. So yes, of course, we're staying local more often than not. But also this notion of, well, you have to go out to tender because a contract is of a certain monetary value. That isn't strictly true in the NHS. The reason that people do it is because they're worried about the risk of legal challenge, which is real. It's absolutely real. Other organizations could come along and say, excuse me, you did not put that service out to tender and we could have provided it. But actually the risks are really quite small when you're talking about the services that we commission locally for our residents and our population. So this notion that it's your legal duty to go out to tender, I think I would challenge that. I think it's an excuse for people to take a formal tendering route, when maybe the more difficult route would be to work with your existing providers.
That's really refreshing, because I think sometimes there's almost like a risk aversion of keeping it like that, because maybe commissioners feel that you have to do things in a certain way and keep doing in that way just in case somebody comes with something. But actually, if it's working for you and the community and the people that are getting support in that way, then it makes sense to carry on doing it that way. Do you find that you've had any obstacles or challenges to the way that you do things?
I think just as you've described, people are inherently a little risk averse when you talk about spending public money in the way that I've described. But actually, people think that they are assured by going through a formal tendering process, for example. But in reality, it's no more of a guarantee of an improved service for your population than it is actually saying, I'm going to work with the people who are really local already. Even if you're not 100% happy, and even if your patients and your population are not getting 100% the best service, the best thing to do is still to work together to try and improve that situation. Don't aim for perfection every time. Just make it better tomorrow than it is today. So the biggest thing is the risk aversion that people have in organizations. And when I talk about the South Tyneside approach, which we stole from New Zealand, from Canterbury, by the way, so I'm taking no credit for the innovation that we talk about. But when I do talk to other people, I do hear that was quite a brave thing to do. And again, for me personally, it didn't feel particularly brave, but I do hear that in comparison to how traditional commissioners work, it does feel like it's a different approach, which requires a bit of bravery.
Thank you. That was really insightful. Do stick around. I'm going to bring in our other guest, Melanie, and then I will bring you both in together at the end. But yeah, that is fantastic to hear from someone actually putting that in place. So yeah, thank you so much for that introduction, David.
Thank you, Sophie. It's a pleasure.
Hello, Melanie. How are you? Can you hear me okay?
Yes, I can. Thank you, Sophie. Can you hear me? Because I know my
I
connectivity is not very good this evening.
I know there's gremlins in the system, a lot going on, and I know you've also had a very busy day. So thank you so much for joining us. So we've spoken on here before, but we were with other guests, and it was really busy because we had you on with CQC and a few other providers. So I'm really glad to have you on your own for this stint anyway. And you're the chair of, well, you wear several hats, but you're the chair of Lincolnshire Care Association, and you have also got other roles as well, supporting care providers in the CAA. I think that's right in saying that as well. But you particularly want to talk about your local care association this evening. So I know I've given a bit of introduction there, but if you want to add to it and all the things that you do in terms of supporting people and other care providers, that would be really useful.
Thanks, Sophie. I think, yes, our care association, I think, takes part in almost the kind of alliance commissioning that David's just been talking about, although that's not how we describe it, and has been able to do that more during COVID. And one of the things I've been trying to spread is the view that local care associations representing local providers can work with local commissioners to solve problems quickly, flexibly, and actually can get to the heart of the matter quickly. And I think that's really come into its own during COVID. From little, well, actually, it wasn't little things. I suppose what you're able to do if you're all round the table is to look at a problem and look at it from different points of view. Because if commissioning happens just on its own, or providers try to innovate on their own, particularly different parts of the sector, often you can fix your problem and magnify someone else's by mistake. But if you all sit around the table or around the Zoom as we're doing now, you can get the right solution for the people we're serving, but also often for the public purse at the same time. So I think that's what we've experienced during the last, goodness, 8 months, 9 months. It seems like forever, doesn't it?
Well, this is the thing that made me really interested. When I first spoke to you, we had a chat before we did any live stuff, and we were kind of comparing our experiences of working with commissioners and local authorities. And I thought, and I still think, all commissioners do a fantastic job, because I think it is a really tough job to do anyway. But I was really taken aback by how much coordination there seemed to be. And it seemed to be a really easy relationship that the local care association, which you run, had with the local authority. You were seen as being a really helpful organisation for the local authority to help them join up with care providers where they were struggling to coordinate or communicate with care providers. They did come to you for advice, to help connect them, to help with get key messages through. And this was even before the pandemic. So you had a really good relationship, and it was a positive one. It wasn't a sort of them and us type relationship, which can happen between commissioners and providers. And I don't know whether that was your influence or whether they just got that was a really useful way to work. So there was firstly the fact that you had that relationship, and secondly the fact that it seemed to be genuine. A lot of the experiences that I come across is that there's a talk or rhetoric around co-production, and we want to help co-create how we commission services. But then when it comes to the reality, you see the contract, it's totally different from the conversations that you've had before. So yeah, just addressing the fact that you have that great relationship and the fact that it actually leads to good outcomes for people who are supported.
Yeah, I think it didn't start with me. My predecessor as chair had a long working life within social care. He'd been an assistant director. He'd been around. So he had started to open some doors. I was fortunate that when I joined, we sat down really with our assistant directors and our commercial manager and said, shall we stop talking about fees? We know you don't pay us enough. You know you haven't got any money. So let's park that and let's look at what we can do together. And we do still have discussions about fees every 3 years. and they can be quite difficult, challenging discussions, but we try not to focus on that because it just saps lots of energy. So a few years ago, we had a problem with discharges. The general view was that the only reason the hospitals were full was because care home managers didn't want to go and do an assessment. We sat down one winter afternoon and decided, well, could we try this differently? And that's how the trusted assessor was born. So the local authority gave the care association some money to employ someone who would operate on behalf of the care home managers. And although it was funded by the local authority, they just gave the money and were hands off. So we were able to build up that trust. And then I think Lincolnshire's kind of off to the right-hand side of the country. Nobody ever comes there except by accident. So we do know each other really well. And I would say our relationships, I certainly would see them as colleagues, and I think they would see me as a colleague. We work well together. We're able to say to each other, actually, I don't agree with that, or I don't think that would work. And I think that's a good sign of partnership. But what's been really good, Sophie, is that that's now built into the clinical commissioning group as well. So our CCG, when they want to work with nursing homes, they wanted to try and get more of them onto a contractual framework. And we did that together. We helped the smaller providers understand how being commissioned by the NHS could seem quite daunting, but it didn't have to be. We had joint seminars with our CCG commissioning colleagues. Throughout the pandemic, we have tried to make sure that if the clinical side or the local authority or something that's coming through the trade associations, we try to give the same message to care homes, because we understand that care home managers are really busy. And if it's a really vital message, all three of us will send exactly word for word the same message, so that we're not confusing people. And I think that's really worked well for all of our providers, our commissioners, but most importantly for the people that we support and for our workforce. They're quite generous. Our commissioners are. We started. One of the problems, I think, particularly in residential and nursing homes, is that they don't always know how to talk to clinical colleagues. So they feel like they've been ignored. And clinical colleagues often say that we don't have any facts, because social care doesn't do facts, does it? Doesn't do evidence. So at least that's the view. And we were going to pilot something called Whizan, which is a blue box full of thermometer, pulse oximeter, and blood pressure cuff. We were going to buy 20 of these kits, pilot them, evaluate it, all of that stuff. Then the pandemic hit, and I had a phone call from a colleague at the CCG who said, how quickly could you take that 12 and roll it out over all 300 care homes? Hang on a second. Yes, of course we can do that. The CCG funded the kit, funded the project management. We are now down to single figures who don't have them. Primary care have had training from the Care Association in how to use it. And the fabulous thing last week, Sophie, was we have a brand new care home that's become one of those designated spaces for COVID positive people. And primary care rang and said, can we have one of those blue boxes? Because we know that helps us to work with the care home to really keep an eye on these very vulnerable adults. And that made me feel really heartwarmed, because not only did the care homes benefit from these, but primary care had bought into it as well. So I think that was the proof of our labours.
That is a fantastic example. And the reason I think it is fantastic, because it shows that how a lot against the grain of what you hear in the media is that the NHS really needs to help social care, or that NHS can give us stuff. Actually, we can give them some support, more than just the physical support. We're more than just like a backbone or a Cinderella service. Actually, we're in the business of solving problem solving. That's what we do, just as much as they are. And by having a problem and looking at the solution across our specialisms, it might seem to take a little bit more time, but we're probably there just as much as they are. So I think that's a good example of how that can work. And I think there could be so many more of those examples if you had that type of joint working, and the benefits flow either way. So that's really, really positive. And in terms of your care providers, have they seen the benefits of that close relationship that you're fostering between commissioning and provided services?
I think they are. I think it takes time to build up trust. So it's easier for me to have a conversation with our commissioners if we're trying to put across maybe a problem that providers are experiencing than if one provider tries to talk to one commissioner, because then people get defensive and they hear blame. Whereas what you're not trying to bring blame, you're trying, I mean, at the moment, as you may know, lots of people are trying to support care homes by ringing up and saying, can we help? Can we help? How's this going? How's that going? But often that can feel like a burden for a care home manager. And I've been able to talk to our CCG colleagues and our primary care networks to say, we know everybody's trying to help, but by 6 of you ringing to try to offer help, that doesn't always help. And they've gone, the various people who need to know things have gone away to look at, is there a way that one of us could make the direct contact and then pass on information to others, or at least alert others that maybe some of their specialism needs to be involved. And I think that's been helpful. And the way we work with our public health team, particularly, I would say that care providers have definitely benefited from that, because I speak to someone within our public health team probably 3 or 4 times a week. At the moment, it's almost every day. And we talk about, we need to get this message across. Do you think this would land well? How do we say that? Do we need to actually talk to people? So our discharge team and our public health team speak to our managers either every week or every other week in a meeting that we facilitate. And I think the strange thing is, because it's our meeting or their meeting, it's the registered managers meeting or it's the providers meeting, and we invite commissioning colleagues. Might seem that that's not that different than going to a forum that they have run and we've been invited to, but it does make a difference to the conversation, because you're a guest at ours, not we're a supplicant at yours.
Absolutely. There's a change of power dynamic, isn't there? People open up when they feel that you're actually leading it rather than them. I definitely, I chime with the idea of, just being the intermediary when you've got, as a provider, sometimes you've been through so much with commissioning authority over one issue, for example, and you just feel a bit jaded. So you feel really passionate about talking about anything else, and that clouds the conversation. But sometimes when you have something like a care association like yourself, I know we've got one in our area as well, who can act as that intermediary, it just gives you that bit of strength, and it takes away some of that stress of having those conversations, as well as building up that one-to-one conversation and relationship as well. And just a question for you before we bring David back in. What would you advise providers who are maybe in an area where they feel quite abandoned by their local authority? Maybe you do hear that, or they just don't have that relationship that you seem to have fostered through the care association, and also you're a care provider yourself. So if you've got any sort of nuggets of advice that you would give to them?
Yes, first would be, don't go in and say you're not paying me enough, because that doesn't work. But find another provider to go with if you can. Identify a problem that you can solve together and fix it. It doesn't need to be a big problem, it can be a small problem, and then gradually that builds trust. And when you have to say, I could do that, but it will cost me X, then you're in a much better place to have that conversation. But what I would say is don't sit there thinking that they've abandoned you, because they're probably sitting in their office thinking the providers don't talk to me. So pick the phone up, dial in a Zoom, have a virtual coffee, and try to avoid the question of fees for at least the first session, because I often find that providers can't help it because we are under great stress. There isn't any money in the sector, but it's not the local authority's fault either. So just pick the phone up and have a conversation. Don't sit there feeling abandoned, because I don't know of any local authority commissioners who would deliberately abandon their providers, particularly not at the moment. They want to hear from you. So just pick the phone up. And if that seems too scary, pick the phone up to me and I'll find someone else in your area who can go with you.
Thank you so much, because there are local associations all over the place, aren't there? And you do know about them, so that's really helpful. So communicate, start with the positive, and then roll back if there's how would I fund that if I was going to help with that, and don't be afraid of picking up the phone and talking to your local authority. And I feel that's definitely a good piece of advice across the board. I found myself just neglecting, for example, the regulator, my CQC inspector, because I was so busy with everything else, I didn't think to update them because they hadn't contacted me. And then on our talk where we had, his name's gone from me now, we had another care provider, and he said, I'm always on the phone to my inspector, almost a little bit too much. I was like, hold on, I just forget them altogether in this pandemic. I need to, because they're not crossing the threshold as much, I need to just, so what we do now is we send a weekly update, and we just kind of brain dump everything we've been doing in the week just to let them know how it's going, because they're not necessarily asking us at the moment, because like you said, they're asking us less because it was just too much at the beginning. So we just need to not make sure that we don't forget them, because what they don't know, they can't do anything about. So that's a great piece of advice. Okay, so I'm going to bring David back in so we can have a bit more of a discussion. David, did you want to come back on anything that Melanie has said, actually?
Yeah, I just wanted to say how much what Melanie said really resonated with me as a commissioner. So I think the idea of building relationships and developing trust between partners is really critical. And the only thing I would add to her comments about what could other providers do would be to persevere, because these relationships don't develop in 5 minutes, and therefore stick at it. And if at first you don't get invited in for coffee, then it's probably because people are just as busy as you are. So I would stick at it. And if you do stick at it, it makes life so much easier when you have a relationship with people. Then you can have difficult conversations. For us, we have a mantra about taking money off the table. So we deliberately, as you've said, Melanie, do not start with the money. Start with what we need to do. What is the right thing to do for our people and our patients? And then, okay, let's work out how we can do it, who can do it best. And then we'll have a conversation about money at the end. And that we found really helpful.
Yeah, I agree. Now you've said it, now I'm thinking about the times when I've had the best engagement with commissioners is when I've said there's a problem here and I think it needs to be solved and I'm happy to help you with it. And once I've come with that, then you find I get an email back straight away. But I'll speak to one of my colleagues and they'll say, I've been trying to get hold of that commissioner for weeks now about this payment we haven't had for months and they haven't got back to me. So I'm like, okay, I'll maybe ease that question to them as well. But you're right, maybe we need to start with other things and then try and create that relationship. And obviously the money is important or else we can't pay our staff, but we need to think about the whole picture as well. So I want to move on to the pandemic, and we've had a lot of news out today. People have been talking about these lateral flow tests. They've been talking about the vaccine, and one of I think one of the largest providers in the country was on Radio 4 was saying we're really worried about the logistics because if we're going to do, for example, the new testing system, we're going to need at least an extra member of staff to help us process all these tests for visitors, and when that will cost us X amount of £1,000 for our whole organisation. What do you think the support needs to be for care providers to carry out all of these really positive news stories that we're hearing. But in terms of practical support, we're going to need some more. What, Melanie, do you think we should be asking for as these things come into play?
I think the key thing, Sophie, is to make sure that the communication to our community is coherent and sets expectations, but at the right level. Because I think one of the risks this morning was that everybody thought they could turn up at their care home this afternoon and go in to see grandma and granddad. And I do know lots of care homes have had phone calls like that. But again, by speaking to local authorities and local public health teams, in a lot of areas, we've been able to get a message out saying, yes, it's fabulous, but hold on. We don't actually have the lateral tests yet. We haven't agreed the risk assessments. We don't know how we're going to process them. But I think on a practical base, from a practical point of view, I think particularly for small homes, the guidance on what is a safe environment to conduct the tests and for people to wait for the answers could be quite overwhelming. So I'm looking to our public health teams to actually help us to put that together. We don't want care homes to go out there thinking they've got to build whole new testing centres, or to be frightened that what they're offering, there's even things in the guidance about what kind of flooring you need to have. So I think we need some help from our IPC leads, infection control leads and public health teams, and maybe even environmental health, that our local authority and our clinical commissioning groups have got. Could we have some guidance on what exactly this guidance might mean? Otherwise, I think most care home managers are not going to sleep tonight because they're worrying about how quickly can they bring this in. And our commissioning colleagues can help us take a more strategic view and say, we're going to be fine. By the time the tests arrive, we'll have this all under control.
Absolutely. That's some really good advice, because I didn't really even know what a DPH was, Director of Public Health was, until a couple of weeks ago, when our local association head said, because I run these weekly calls with providers and local authorities and MPs and stuff in our area, and he said we should get one of them onto the call, and I said, who is that? And then realized that they're supposed to be leading with the guidance on visiting, and of course this is all about visiting, so that they are the people we should be going to asking for extra guidance on this. So yes, very good advice. David, have you got any thoughts on the new testing system?
I think there's a couple of things for me. Firstly, this will get to the heart of whether we really do value social care and care generally on the same level as we do health and healthcare. So we talk about that. Well, now is where the rubber meets the road. So are we really going to say that care home staff and providers and the residents who are living there, because that's where their lives are they really as important as people who are living and working within the NHS and in our hospitals? For me, it's a no-brainer. The answer is yes. But actually, you need to put your money and your support where your mouth is. So I think we've started this pandemic with the mantra of protect the NHS. Actually, we need to start protecting some of our vulnerable people very practically. So I think this is a big test. I think that your local CCG and local NHS can help probably more. I think some of the care home providers are very small, and to expect them to be able to put in place some of the things that Melanie has already raised, I think is unrealistic. So let's reach out our hand with support to them and say, we, the NHS family, can help, because we're all in it together. So I think it's both a big and a very local practical issue.
I wonder what that help would look like. I just can't, because that provider was saying on the radio this morning, they felt that they're going to need an extra member of staff to put through that. And I'm thinking also, if you've got the compound issue of the new testing, and you've got the vaccination as well coming into play maybe in January, you've got two of those things intersecting, plus the fact that maybe there's been a little bit of lag with flu, so maybe that will come in January. Do you think they're just going to have somehow, like you say, CCGs may just have to free up some of their staff to come and help us out in some way?
Personally, I do. I think it's very practical. It is all hands to the pump in this situation. So clinical staff who are maybe not in current clinical roles will need to be moved. I think this is very practical kind of, we are going to have to put boots on the ground. And I think some of those boots need to come from the NHS. Now, you might say, well, it's easy for you to say that now, Dr. Hambleton, because you're not now running a CCG. But I would have been saying that if I'd been running our CCG today, because that is the only way that I think some of our care homes are going to be able to manage this current situation. And if we don't support them to manage it, then we'll all end up in trouble, because what will happen is we'll get uncontrolled local outbreaks, and then our hospitals genuinely will be fuller. So I think we need to start moving things upstream much more practically.
Yeah, and that does ring true. Melanie, do you think the same thing, that we're going to have to start putting boots on the ground and supporting social care sort of with personnel from health?
I think we may need boots on the ground, but I think more importantly, we need eyes on the prize. I think most care homes now have access to e-consultation, but it's not as widely used as it could be and should be. So that if we are, as care providers, are helping our clinical colleagues to do whatever they can without coming into the care home, then when we say, but would you mind coming in to help us with the testing? Because we all know that the lateral flow testing works better if it's done by someone who really knows what they're doing. So I think it's about working together, because there may be some clinicians working in CCGs and local authorities who are not currently patient facing, although most of them are being joined to acute trusts often and community trusts. But I think we need to work both ways. If the care provider can do as much as possible without the clinician coming into the home, but actually what we need is, we could do with someone there for 2 hours every morning to get everybody's tests done, so that we can have the visiting in the afternoon, then that might be a reasonable ask. But I think David's right. We've got to sit down together and say, this is not about us and them. But I don't think it is about us and them in most places. I mean, we talk mutual aid. I think the problem is we all want the mutual aid at the same time, and there isn't anybody to mutually aid each other. But I think this is an area, and I hadn't thought about it, David, this is somewhere where our district nurse could probably do in half an hour what a care home senior carer would probably take 4 or 5 hours to do, because they wouldn't be as good at it. And we need to be honest to say, this is not our forte. You know, I know the lateral flow is relatively easy to manage, but it's not what we do. But it is what some of our clinical colleagues could do without thinking. So I think that's a really good suggestion.
Yeah, I mean, I'm thinking about the smaller care homes, because obviously that's what we run, and we don't have we've never done nursing. Yeah. I've never gone into nursing care. I also know that my managers are, we're in a much better place than we were in March and April. That was pretty stressful. That was that was very scary. But I do feel that there's a lot coming down the line for them, and just forward thinking and having these conversations, exactly what you've been saying the last sort of 4 to 5 minutes now, about how we're going to manage these things. Smaller homes who don't have the clinical staff, who are going to have to go through a lot of training and then implement it and then operationalize it, and also do the day-to-day part, and then think about how other things might, like the flu or other things, are going to impact people. I think we've lost Melanie for a sec, but that's fine. It just all kind of compounds, and I'm just thinking this conversation is absolutely what we need to think about in actually bringing forward any of the stresses that are going to happen. Just before we finish off, I do want to cover the vaccines, and obviously that's really, really good news, but like I said at the beginning, there are some questions about the vaccine, and not everybody's lining up ready to have it. If I wasn't 6 months pregnant, I would be. But do you think that we need to do a little bit of groundwork in preparing our staff for the vaccine, and giving them information that makes them feel comfortable about taking it? Maybe David, you can cover that first.
Yeah, I do. I mean, I think that while we've all been eagerly awaiting the vaccine, I think the speed with which it has arrived has got some flip sides, because people are now questioning the efficacy and the safety of the vaccine themselves. So they're going, well, hang on, if it would normally take you 5 years to do this and you've done it in 5 months, am I going to be the first person in the queue to have my arm jabbed? So I think there's been a tremendous amount of work done collectively, and the collaboration around producing these vaccines has been fantastic. And we don't often see that, particularly within the pharmaceutical sector. So it is great. It's to be welcomed. But I think, Sophie, you're absolutely right. We need to get our comms absolutely nailed on about how effective, how safe, and how required this vaccine is, because we're all under great pressure in terms of the isolation measures that we've had to endure over the last 9 months. They're incredibly stressful, and the only practical way of actually loosening those is to get vaccination uptake really high. So 30-40% uptake of vaccine is not going to cut the mustard for us. So our comms needs to be really, really tight and very joined up. There shouldn't be anything between the messages from any of our sectors. I think that's the most important thing.
Yeah, that seems very sensible, David. Melanie, do you have any thoughts on how we make sure we get the vaccine out to as many people working in our sector as possible and make sure they're confident about it?
I think I agree with David, and I think this is another area where, particularly locally, we need to collect. We need to make sure that we're all dealing with the myths in the same way, and being, how can I put this? We really need to be excited about this. I mean, I've heard people today saying, oh, well, it needs to be care home residents first and staff because they're guinea pigs. And it's like, we have been fighting for all the years I've been in the social care sector to get parity with our NHS colleagues. Now we get, and you're saying, oh, there's got to be a catch. Please, let's embrace this opportunity. Yes, it has been done quickly. But that's been done quickly because the best scientific minds in the world have been working together on it. I think it's fabulous. I just wish there were 8 million coming on the way to us rather than 800,000. But there will be people who are frightened because there's all kinds of rubbish out there saying, oh, it's a conspiracy and, it's going to include a tracking device and all sorts of other spurious ideas. But we need to be thinking carefully about the message we put out. And we need to be supporting all of our staff and our service users to take up this opportunity, because you're right, David, it's the only way out. And I don't know about anybody else, but the thought of being in semi-lockdown and worrying about whether there's going to be enough PPE next for longer than we need to do, no thank you. Let's get back to doing what we do and do well and living life, not living a half life.
Thank you. That's really nice to end on an upbeat message. And I know we've had a bit of sound quality at the issues at the end, but we pretty much got the gist of that, and that was really, really good to hear. So thank you so much, both of you, for spending the hour with us this evening. Some really good messages. I definitely want to take some clips from this and share it on social media, because I think there's some important messages that people need to hear about commissioning and about what you've learned from the past and how that can absolutely influence how we do things in the coming days and weeks as things are changing. So some really, really helpful insights there. So I will leave you for the rest of your evening. It's been a long day for both of you, I'm sure. Thank you both very much, and do take care.
Thank you. It's been a real pleasure.
Thank you, Sophie. Nice to meet you, David. Bye.
And you too. Thank you.
Great. That was really helpful. And I hope you all enjoyed that. Definitely, if you did find it useful, if you want to hear more about commissioning, we'll be doing another one next week, next Monday at 5 o'clock. So do subscribe to our YouTube channel if you're watching us on YouTube, and follow us, and press the like button, thumbs up, as people say, because that just drives more people to this message. And I think more people do need to hear it to understand what goes on in social care from our perspective, people who actually provide and use and are interacting with services. So I think that's where we need to have our messages coming from the ground up. So do definitely engage with what we're doing. And like I said, if you want to find out about the results of our questionnaire, then join our mailing list and get onto our website. There's lots going on there. But otherwise, we very much look forward to seeing you again next week. Have a lovely rest of your week. And we will have some more news around commissioning and vaccinations and so much more. So take care, everybody.